My name is Amber Clevenger, and I'm here with Nick Mercadante, our CEO and founder, to talk about Medicare and Medicaid and the behavioral health gap that exists. Why is this such a problem?
The problem starts probably before you even start talking about what, healthcare benefits somebody has. Really, it does go back to socioeconomic factors and factors of health equity that are pretty ingrained in our society. There's data to support that there's clear disparities in health access and mental health access for people that are living rurally, that are living below the poverty line, different races, language, gender. All of these things affect access to healthcare generally and access to a lot of resources, right? So it starts there. But then when you look at it deeper, and specifically in mental health care, I cannot find a therapist, period, in this geographic region of the country, right? And most of that is I think, coastally, there are a lot of healthcare resources. But when you get, further into the middle of the United States, rurally, or northern New England, places like that, where there's expansive geography, there's just not ready-made access to any type of care, even before you start touching on things like stigma and cost and do they speak my language and do they understand? It just isn't there, and the data supports that. We as a country can meet somewhere, depending on what study you look at, somewhere between 25 and 35% of the known need for mental health treatment across the country, and that's just the known need. That's
well, that's not even a lot of the known need.
That's the part of the iceberg
Right.
We can see. There's a lot that we don't know about. And to make matters worse, because historically mental health care and specifically substance use disorder has been highly stigmatized, criminalized, and something that we don't talk about with our everyday healthcare treaters, it exacerbates that problem. You have that unknown need, right? The people that are suffering through this and they don't come into contact with any type of preventive care. They really don't come into contact with any type of care until a true crisis. Bringing it back to Medicaid and Medicare, right? A lot of that population meets those socioeconomic criteria factors. When you are a Medicaid patient, nobody will accept Medicaid. The best psychiatrist won't accept it. The best therapist won't accept it. Maybe the only game in town, the only provider in town just doesn't accept it. Well, now it's really stacked against you, because not only is it stigmatized, not only you can't talk about it with your primary care provider, psychiatrists won't see you because you can't afford it, right? You're kind of forced to the emergency. You're forced down that ladder into crisis, and then, at that point, it's crisis care.
So this is the current state of play. Did that sort of inform PursueCare's footprint and where we offer care?
100%. When we started looking at this space, what we were seeing was this increasing prevalence of an unmet need that was hitting all these different levels of care, and nobody there to treat them, right? And then what's worse is if there's nobody at that point of care, there's also no connective tissue to somebody else that could treat them. A ready-made pathway to say, hey, look, I can't treat you as a primary care provider,
but I can put you in touch with.
Yeah, I'm connected with somebody else who is a specialist that can handle this. And so that's what informed starting PursueCare. And we specifically saw it in these rural pockets where there's just nothing, right? And where they were desperate for help. And that's really the foundational thesis around PursueCare.
Great, thank you so much.